casi 150 personas que están conectadas. Muchísimas gracias a todos. Y bueno, hoy la sesión es con mi amigo, el doctor, el profesor Filippo Graziani. Antes de iniciar esta sesión, que es la sesión número 26, queremos darle una felicitación a todas las madres bolivianas, porque hoy es el Día de las Madres en Bolivia. Feliz día, mamá, en Bolivia. Felicidades a todas las mamás. Sabemos que muchas odontólogas son mamás bolivianas y bueno, pues muchas felicidades a un país hermano allá en Bolivia. Y bueno, Filippo, are you there?
Of course I'm here. Of course I'm here, my friend.
Oh, wow, pues a pleasure to be here with you. Todos sabemos que la charla del día de hoy con Filippo Graziani será en inglés. Esperemos la interacción de todos ustedes. Filippo es un gran amigo. Filippo, thank you for to be here in this classroom, this virtual classroom. You're a great professor of periodontology. I read a lot about you in the past, and now, well, it's a honor for me to say you a friend. I talked to all the people that you are making some studies for this pandemic situation in periodontology and all about attention of care for our patients. Well, first of all, thank you so much. Our students are very grateful for your presence here. Your presence here in Latin America make us so happy. And well, thank you again for being here.
Thank you very much, dear Carlos. It's a great pleasure. En primero, buenos días a todos de México y Sudamérica. Disculpa, pero mi español es terrible. ¿Cómo voy a hablar en inglés por todo el webinar? Mi español es bueno por la noche, por la comida, pero no por el webinar. Then, unfortunately, regretfully, I have to switch to English, although I think that if I would speak Italian, most probably you will all understand me. But it is a pleasure to be here and with the Perio MX Academy. The topic of today is really to try to focus a little bit on periodontal regeneration, especially minimal invasiveness. But the main focus will be on trying to deal with what I like to call unconventional defects, complex defects. I'm sorry I didn't dress properly, but I was literally treating a patient till 2 minutes ago. So I really had to rush in, and therefore I apologize for hairs and so forth. Okay, but I'm sure you will apologize me.
No, it's okay. It's okay, Filippo.
So
I already named you like an editor for this page, as you can share your screen right now. So fantastic. I talked to all the followers. There is around 150 people connecting right now in Facebook Live, and we are talking about minimal invasive surgical technique for complex defects. So we are very motivated with your lecture. So welcome to your classroom. This classroom is yours. Welcome to all Latin America and to Mexico, and viva la Nutella.
Viva Nutella always, siempre. Now, can you see my screen? Can you see some slides?
Yeah, it's okay.
Yeah,
good.
Yeah, very good. So once again, thank you, everybody. It's been a great pleasure. And now I'll try now to focus a little bit on the need for surgery and understanding really the important aspect of the fact that surgery, it's a crucial aspect of perio, but it's one of the aspects. Treating perio is more than doing just a surgery or doing something nice. Treating perio is to deal with the persona, with a human being, changing his or her life, try to connect with these people, try to give them the power to change their own life for the better. And therefore, applying whatever we need from non-surgical and surgical in order to restore what we got. So what I think it's important is, for example, if you see this case, this is Roberto. You know, Roberto, when I saw him, it was 2004. I had just came back to Italy from my specialty. And I was treating Roberto. Roberto, back then, at 34 years old of age. You can see that Roberto was severely affected, actually, by the disease. Now, if you look this slide, you will see numerous cases that are really intense. These are all stage 3 cases of generalized periodontitis. And what we know, in fact, that periodontitis affects the majority of the adult population, would determine tooth loss, and is associated with systemic disease and a lower quality of life. So why do we? Our treatment goals, in fact, are to arrest disease progression, to nullify symptoms and perception, possibly to restore and regenerate teeth that have been lost. But most importantly, wherever we do, we want to maintain and support, therefore to keep teeth for longer. So it's a bit tricky because you see, the main difference between perio and the rest of dentistry is that we don't really cure anything here. It's not that I remove a wisdom tooth out. It's not that I treat a caries and the caries is not there anymore. The problem that I have with perio is that the best I can control the disease, but I don't remove it. That's why it's important to understand which are the factors that are associated with disease progression, because my treatment has to deal with changing these factors. Now, once I get this in board, that I have to have numerous phases to treat periodontitis. If you see these cases, our goal is to change them to an extent they can be managed out time. So the point of a periodontist is not to take teeth out, but maintain the teeth that are in position. And sometimes we really need to struggle, but there is always a way. And sometimes, and I have to invite you, all of you, to read my Per Campus Herald, which is the journal that we just recently released. I think what is important is that a tooth is hopeless only when you take forceps and take it out. There is always hope. There is always some possible treatment in the majority of the cases, even when you don't think it is the point. So treatment per se is actually going through 3 different phases: the non-surgical, the surgical, and the supportive maintenance. But bear in mind that the surgical is a very fine and detailed procedure. Now, when I have, of course, a site that presents a significant defect, what I have to do is more or less to instrument. And the instrumentation, I mean, the highest level of evidence I have on instrumentation is basically ultrasonic and curette altogether. And although I can tell you that now with this COVID pandemic, now that we are testing every treatment in terms of true aerosol and particles production, I can tell you that I'm relying more and more on manual curette. Although I have to say that one of the problems that we have in contemporary periodontology, that a few people, little people, knows how to use curette properly. Everybody wasn't really trained to use curettes, and I think it's important that curettes are properly passed. So really, that's the beginning, and this is afterwards, 3 months afterwards, you can see the pockets closed, despite it was a severe pocket. So the point, how can we actually go to a stage where we can successfully treat any type of disease? Now, one of the, I think, main concepts that we have in periodontitis and periodontal treatment is that the healing per se is very, very complex. Now, let me focus, in fact, for a little bit on the periodontal wound. Now, what is happening once I open, clean, and close, or whether I place a material or not? You see, a logical standpoint, this very little defect is actually one of the most complex biologically to heal, because if you think about that properly, you do have some soft tissues, and the soft tissues are highly vascularized. You have vascularized mineralized tissues, and these 2 areas, in a way, are providing blood clot, and at the same time are stabilizing the blood clot because they're highly vascularized and they're rough. But then you have a very complex area, which is the root surface, because it's a mineralized tissue that is completely and fully avascularized. That creates tremendous problems because the presence of a smooth avascularized surface would tend to delocate and change the stability of the blood clot, which is the primary engine for the healing. So whenever I suture here, underneath over there in the oven, something strange. change. There is a blood clot that wants to attach somewhere, but there is a full area where there is no attachment whatsoever, or very little attachment, which is the root surface. So years ago, we tried to understand, that was actually the thesis of my specialty, the dynamics of periodontal wound dealing in complex defects, such as the Essence type of defect. And ideally, what I would like to have is to achieve a new attachment, a supraalveolar new attachment. You know, sometimes we focus on periodontal ligament, but periodontal ligament, it is really not the issue per se. It's not bone what is needed. It's actually a connective tissue that attaches to cementum. Whether there is bone or not, it's irrelevant, but we need to have this new attachment. What happens when we do our routine surgeries, that most of the time, we'll end up, in fact, with the so-called long junctional epithelium. So there will be a sort of a reparation. And the reason for that is that most probably the blood clot is not stable enough because the smoothness of the root surface. So in fact, the long junctional epithelium is really not the healing that we have. And the reason most probably is this delocation of the blood clot. We know from the classical study from Ulf Vickershaw that if you treat with heparin a wound, the healing will be surely in favor of long junctional epithelium compared to a to a new attachment. So the complexity that we have when we have surgery are four. First of all, whenever you do your surgery, you'll have a patient that wants to go in the middle of the wound. Secondly, you have an issue to try to stabilize the blood clot. Now, blood clot to stabilize is actually very complex. It is very complex because, as I said, there is an issue on the fact that the root surface will tend to destabilize. So the higher the amount of root surface that is in the wound, the lower will be capability of the blood clot to attach. That's why, for example, forcation are so key from a surgical standpoint. But it is not just about blood clot destabilization, it's also about wound contamination. In fact, the presence of the root surface also would imply a higher level of plaque, which is bacteria that destabilize the blood clot itself. And lastly, you have to bear in mind that when you have a defect that is created, there is an issue of space, and space is crucial in terms of achieving a proper healing. So the principle that would guide your surgery is, first of all, to try to achieve a space between flap and the root surface, to possibly achieve a proper blood clot stability, and also to have a soft tissue protection to avoid bacterial contamination. Now, how do you achieve the first two? Well, basically, the usage of material would allow you to obtain some space creation and to enhance blood clot stability, whereas the usage of specific flap would support your blood stability and also soft tissue protection. So the way you choose material and flap would allow you to achieve your surgical objective. So what is the decision process? Well, first of all, you select the patient, then assess the type of defect or papilla, then you choose your flap using possibly a minimally invasive concept, and then whether the defect is supportive or not, you'll choose a material. So what our group tried to do in the last 10 years was really to try to provide the base of the knowledge of surgical techniques. And therefore we ran 3 studies on whether the surgical healing was different in intrabony, suprabony, or forcation type of defects. And you see, what is happening when I have an infrabony defect like this one and I open, clean, and close? Just 1 second. That's okay. What is happening is that basically the cleaning would result, as you can see, complete closure of the defect at 6 months and 1 year down the road. So what is happening is the surgical of an intrabony defect is actually, in this case, conducive for defect resolution. So what is the healing that we might expect? Well, we know, in fact, that on average from our study, we should gain at least 3 millimeters of pocket reduction. And that's what you should expect when you're doing and dealing with such defects. And patient is actually crucial. You know, you need a patient that is polishing correctly, and therefore horology instruction are fundamental for the surgery, but also inflammation has an impact on the healing. We know, for example, as you see in this case, where there is an abscess before surgery, that you see this very steep intrabony defect, in which basically what I'm doing is I'm pre-instrument with some chlorhexidine in order to have a better soft tissue. And you can see now the surgical phases, this is a huge defect. You can see there are 19 millimeters of attachment loss on this defect, which is going to be treated with the bone filler and the collagen membrane, and that's before and after. Or look at this one where we had an abscess once again. In this case, the presence of inflammation would reduce our healing, and therefore I'm just going to do some quick instrumentation 2 weeks before the surgery in order to have better soft tissues, and then the surgical with a mixed technique with Emdogain and Bios together. That's the healing before and after. So, but smoking also has an impact on the type, because smoking is crucial. So some characteristics cannot really be changed, like age and race, but surely a stringent control plaque is needed, and even negligible plaque levels can actually be removed because they have an impact on the healing per se. Do let me please change a little bit and get a bit faster, because I realize that I choose the presentation that is a bit too long, otherwise we'll stay forever here. But what I think is important is that in infrabony defects, what was shown by our group is that there is a differential effect according to the type of flap. Basically, more minimal invasive you are, the higher is the healing. So that is really the base for suggesting the removal of a minimal invasive flap. I'm sorry if sometimes you hear me that I'm slowing down, but I'm trying desperately to have my team switching off my air conditioning and they don't understand it. So excuse me. La vogliamo spengere, cazzo? Grazie. Thank you. So the clinical performance, you can see, is actually very relevant. Now, if you check this defect, we have 14 millimeters of attachment, 13 millimeters of pocket, a very steep defect mesial to the canine. Now, what we do, you see, we are doing our flap, which is, however, designed in a way that we are not gonna touch this papilla. I think this is very important. As much as we open buccally, but the papilla in between teeth is gonna be left here, attached actually to the lateral that didn't actually have pocket. Therefore, there might be some connective tissue attachment that keeps the papilla high. So what we do, we are really excavating underneath the papilla, as you can see, till the moment that everything is clean. Now, you see, this is a severe case, but what was particular is that the patient was allocated, he was part of a research, to a group in which no regeneration was allowed. So I cleaned this defect, 14 millimeters, and I simply sutured just by using a minimal invasive surgery. And this is before, 12 months afterwards, with 6 millimeters of attachment gain. 6 millimeter attachment gain is a huge amount of attachment gain. That was achieved without material. That was achieved just by playing with blood clot stability and soft tissues. So flap is crucial, and we know that minimal invasive flap do present the higher results at the moment in intrabony defect. But we also know that materials, for example, guided tissue regeneration, which is now mainly played with the collagen membranes and xenogen, amelogenin, that of course, as you know, are important factors that can be applied for regeneration, or a mixed technique with the amelogenin and xenogen, are the three techniques, and you see here before and after regeneration once we finished our surgery. These are the three techniques that presents the highest amount of evidence Superbunny defect. So the usage of these techniques, all together with the usage of minimally invasive flaps, do allow to play with your wound during the healing process. Now, taking this concept on board, and let me move this on complex defects. And let's start with the defects, which are the defects that are involving defects. So-called perioendo lesion that needs to be regenerated. Now you see we have this defect. This tooth was sent to me for extraction and implants, but of course, being quite a stubborn periodontist, my idea was to try to restore it. Now, as much as you see, we opened everything, also did a very fine and minor apicectomy. What actually we did was not to touch this papilla. So you see, the defect is peculiar and it's very advanced, but we are not touching this papilla because we want to preserve blood clot as much as we can. But in this case, if I would have put the flap back, the flap would have collapsed on the root surface, therefore removing the space during the wound. So whenever I need space, I need a filler. That's why I needed the application of axenogen and a coperture of a collagen membrane, because whenever I place axenogen, unless I place endogen before, I need to place a membrane. And then you see this is the suture. This is 6 months of healing, 1 year, 3 years, and this is 5 years down the road. You see, the pocket is closed and the tooth is still there. A tooth that was sent to me for extraction. That is the objective of a periodontist. Well, and look at this case. This is a 14 millimeters pockets. It's a canine. You see the defect is huge. We open, and once again, we take on board that the papilla will actually stay because we are applying once again the concept of minimally invasive. What is the difference between this defect and the one that we saw? We have this band of bone here on the buccal side that in a way allows the wound to be secluded. Therefore, the end result is that I don't need to create space because the space here is self-maintainable, and therefore I would use an amelogeny. You see, I'm using amelogeny here, and this is the healing after 1 year. You see the pockets is closed, so we went to 4 millimeters to 3 millimeters. This is before and after 1 year, and you can see the x-rays. And this is 3 years down the road, and you can see the probing that is maintained. And I think this is important. It was a tooth that was hopeless with an abscess, with the 14 millimeters pockets. And now you can see we are pressing very hard, but the probe doesn't enter. Remember that the x-rays are for the shows, but the probe is for, that's the most important thing. When you go back home, you need to probe, and the probe doesn't have to go through. Then that is when you know that you did your job. Now, let me move to an even more complex defect, which is the type of defect. Dehiscence is crucial. You know, this is part of a research that I did ages ago, that when we did surgeries on monkeys, and we established that you can achieve regeneration even in the dehiscence type of defect. The regeneration will be functional to the presence or not to the bone. So 6 months down the road, when you have new bone forming, you'll have a new periodontal ligament, and what is happening is basically that the function over influence the healing. So you will see the cementum that gets grow and bigger and bigger. So you see, we have this defect here. We have 15 millimeters to the apex, complete absence of the buccal bone, so it's a dehiscence type of defect. In this case, obviously, I could not possibly apply an amines because then the flap will collapse. So I'm bound to actually apply axenogen to maintain space. We cover it with a membrane, and then we suture it. That's the healing after 2 years. And this is, you can see, is the classical probe that we have in Pisa that is leaning like my tower. And that's the healing. This is the healing after 4 years. But check once again. We had 1 millimeters of recession more, but look, we went from 14 millimeters to 0 to 1. So that's what you need to assess. That's the most important thing that you do in regeneration. So let me move even to an even higher complex defect, which is the Superbunny defect. Because you see, Superbunny defects are crucial because you have 2 root surface, so you have a higher amount of root surface. You're asking your little blood clot to stay here and remain stable. And you realize biologically what a challenge that is. To be honest, it's impossible. That's why Superbunny defect and craters are crucial. You know, Superbunny defect are horizontal defect, but they're so important because, you know, we focus so much on infrabony defect, but in reality, the majority of the defects are horizontal, they're not vertical. So let me check this patient. You see, we have some defects here in the premolar that are residual to non-surgical instrumentation. And therefore, we start with just a classical papilla preservation flap. So we maintain the majority of the flap on just one side, which is the palatal side. You see here we close it, and you see that was before we started with the 6 millimeter pockets, and that's the end. And this is actually 2 years down the road where the pockets are closed. There is just a bit of bleeding mesial of the because Luca is really not the best in plaque control and is actually smoking as well, but the pockets are still closed. So the healing that you would expect is something that we did measure it a few years ago. You see here another papilla preservation flap. We open and close, and that's the healing before and after. So on average, we've achieved a 3 millimeters pocket reduction and attachment gain of 1.5 millimeters, which is very much what you would expect from your surgery, as we showed in 2014. But what appeared also relevant is, first of all, that flap has an impact, but what has an impact in general is the application of amelogenins. The highest evidence that we have of regeneration of Superbunny defect is with the application of amelogenins. That would give you, on average, 1.2 millimeters more gain. So let me show you this case. You see, this is a pretty advanced case. This is Sarah, who is a lovely capoeira dancer, a patient of mine that tried to bring me to capoeira all the time, unsuccessfully. But, you know, she started with 7 millimeters pockets on both sides, and there is no bone whatsoever. So we open with the papilla preservation flap, and you can see that there is really a challenging defect because there is no bone that could support a blood clot here. Blood clot would just not stay, and the flap will collapse on the wound. So in this case, due to the data that we highlighted, we've applied amelogenins, and you see here the application of Emdogain, the suture, and this is, look carefully the healing. This is the healing at 6 months. Now look what happens at 1 year and 2 years. Can you see the papilla is growing back? That is what we call. So we went from a 7 millimeters pocket to a 2 millimeters pocket. There is no changing from an X-ray standpoint. That's why it's so important to take probing, because in complex defect, bone will not change, but what is changing is the connective tissue attachment. And you see the pockets are now closed for Sarah. So we've actually sorted the situation here. So let me now move to craters. Why craters are important? Craters are crucial because they are a kind of a mixed defect, because in a way they're infrabony because there is a valley, but on the other hand, it's like a superbony defect because you have two root surfaces in the wound. That's why the way I treat it mainly now is, I mean, ideally, I was taught to remove the lingual component of the bone and to create a ramp. But to be honest with you, I can possibly think in 2020 that I need to remove bone to solve a defect. So what I'm doing now is, we've just started a very important grant, a multi-center study worldwide to try to do regeneration of craters. And the way I do it is basically this. You see, we open with the brighter craters, then we apply amelogenins. So we treat the two root surfaces as they would be a Superbony defect, but we treat also the concavity with some xenogen to support the wound. And this is before and after. And you can see with the closure of the pocket, it is 14 months after the surgery. So it's just above 1 year. I mean, ideally, in the past, I would have treated this by removing tissue, whereas now I'm trying to add things and to restore, not to remove anything. Well, look, for example, this case, which is more complex. You see, we are in a situation where we've lost 12 millimeters on a lateral, so it's very important. So once again, you see, I open the flap and you see, I treat the flap always the same. So it's a minimal invasive approach. I'm leaving the tip of the papilla there. I'm making underneath, but I'm treating the two roots as a Superbunny defect. So I'm applying amelogenins. But then, because I also have some bone concavities, I fill this up with bone filler. And then I cover everything with amelogenins again. And then I suture it. And this is before, and this is afterwards. This is 1 year after surgery. And you can see that the defects is solved because there is no residual pocketing left. That's why I always like to put the video of the probing, because that is what is crucial. Is the probing that makes the difference. That's when you know that you achieved your job. Because when you go and check the x-rays in complex defects, such as the horizontal defect, you will not see differences throughout time. So let me move now to the last few minutes to focus a little bit on the fabrication defects. You see, now you realize on the basis of what we said, why fabrication defects are the most complex one. Because what we have here is basically 3 surfaces that are made of root. There is plenty of bacteria because it's very complex to the granulate over there and to the brachytely. So biologically, you're asking your blood clot to fill this wound, this void, and try to stay by itself. You see, this is very complex. That's why forcation are so complex to heal. The problem is that forcation do tend to increase over time. So with the time, we have more and more forcation. That's why it's crucial to treat them as soon as you can. You see, ideally, this is a relapse on a forcation, a patient under maintenance. And you see here we do non-surgical treatment with ultrasonic curette. In this case, also did apply some photodynamic treatment with lasers. And there is a change, of course. We have an increase in attachment gain. There is no pus discharging, but the forcation is not solved. In fact, the main problem is the anatomy. It's very complex to debride properly a forcation because that very peculiar anatomical features that do present. And in fact, we know that the higher is the access to forcation, the higher is the level of root debridement, especially to the dome of the forcation area. That's why we need to do surgery most of the time on forcation. So the question was also done by a group, and we wonder, how's the healing of forcation when an open, clean, and close? You see here, we just access the forcation surgically, we debride it, and this is before and after. We had some oral attachment gain and things have changed, but how much that happened? Now, when we measured it, it was very clear that the healing from a horizontal standpoint is very little. It's around 1 millimeter of attachment gain. Therefore, open, clean, and close a forcation is not a good approach. And in fact, we know from other studies that we performed that you give regeneration of forcation as well, provided that you have a blood clot stability and a proper decontamination. So in the recent EFP workshop, the group I was part of with some friends was the one dealing with regeneration. And I was responsible of actually the regeneration of forcation altogether with Professor Soren Jepsen. So myself and Soren Jepsen tried to highlight the evidence that we have on regeneration of forcation. In order to do so, we have established a study that taken on board the most fine, one of the finest technique that we have in evidence-based dentistry, which is network meta-analysis. So the way we did apply network meta-analysis was to try to see what was the best technique, and it was crucial to understand when we instrument forcation. So it could be a graft, and it could be also an amelogenin, and best even a mixed techniques. So for example, check this defect, which is very complex because I have 2 forcation type defect and an infrabony defect. So I have a multiple type of defect in this area that is characterized by both infrabony and forcation. So in this case, I open, I clean and debride, I apply some amelogenins, then I also apply some xenogen, then I reapply amelogenins, and then I suture. This is before and after. You can see that in the first forcation, we are still degree 2, but we have achieved 3 millimeters of attachment gain. Whereas we've changed the second forcation, which is now a degree 1, and we cannot enter more than 3 millimeters. And we close the defects on the distal root surface of the 4.6. So do let me conclude, and in case you have some question or some doubts in these days, you can write me on Instagram, because I've stopped using Facebook. So please, any doubt, just check me out on Instagram and I'll be happy to reply. But most importantly, surgery should be done when non-surgical treatment is destined to fail. It's important that we do surgery to reduce indicator of tooth loss. And I think regenerative techniques are now the gold standard. And I think that's something that we've highlighted even in the last EFP consensus conference. Therefore, to me, whenever I have a defect, I'm trying to apply concept of minimally invasive surgical technique and using the material, because regeneration is the gold standard. The rest is a variation. So always try to use a regeneration, because that's where we have the highest level. So, my dear Carlos, I'm now gonna stop the screen to share.
Yeah.
And I'm here for any possible question, and I'm also trying to highlight some other slides for showing even a bit more on even what we can do when it comes down to, for example, trying to use regeneration when opening a flap, which is the new frontier, and trying to, the thing that I'm doing the majority of the trial now.
So thank you very much for your presentation, of your lecture. And one of the things that we see in Latin America, and I think that some clinics do, is put or mixed a membrane, a collagen membrane plus endogain. So we see in your lecture, and we read a lot about this kind of procedures, and we know that it's not necessary to mix them. But what is your opinion about this kind of clinicians that teach that it's possible in a wide defects put a collagen membrane and plus endogain?
Well, I wouldn't see the biological rationale to mix membrane with endogain. I mean, a membrane stays there to protect a graft. Well, unless the membrane is stiff enough to maintain the space by itself. But the membranes that are on the market now are most of the time collagen membranes, so they're not stiff enough to maintain the wound. So if we're talking about a collagen membrane, then you need a graft underneath, no discussion. The concept of the graft is not because the graft has any possible magic properties. The graft is important because it allows you to maintain space. So the issue is that when you use a graft, you can either use a membrane or an amelogenin as well, because we know that endogain and graft do work as well. So, but I wouldn't really use membrane and amelogenins together, because first of all, I don't think you need it. I think it's, to be honest, it's too much. Biologically, they work on a different type of action on the wound. And by placing too many things in the wound, things may even compete or create some problem, because membrane would also increase the chance of wound dehiscence. So I would consider the amelogenins only alone or with the graft, but not with the membrane.
Another question that is common in Latin America, and we are discussing a lot in the last seminars, is that the possibility to detoxify the root surface with EDTA, 24%. Here in Latin America, there's no places that we can find this kind of detoxified, like Pref gel. In Central America, we don't have Stroman. We don't have the possibility to buy this kind of detoxified. So we see that if the root is only clean by, I don't know, like peroxidine, or I know if it's a serum, so it's enough. What is your opinion about not detoxify the root surface?
You don't need to detoxify even Pref gel. I mean, there is some evidence, and it's been published, that Pref gel per se do not enhance the healing. So by using Pref gel to detoxify only without applying amelogenin doesn't give you anything more, to be honest. So I wouldn't really, I wouldn't really go in that direction at all, because Pref gel makes sense if you apply endogen. Pref gel per se doesn't get you anything, and we know that's been published already, but actually we know this very well because of our study on surgical amelogenins and control. So we need to find out whether the ADTA was creating any action, but it doesn't. So I wouldn't suggest to detoxify on proper, good instrumentation, which is still the gold standard.
Super. Another question. Well, I know the answer, but in Latin America, there's very popular PRP or PRFC, no? So what's your opinion about field defect with this kind of devices, like platelet-rich plasma?
Well, I mean, I've been using platelet concentrate a lot when I was really at the beginning of my career, and I have to say 20 years ago. I was, of course, 12 back then, but anyway, we did use PRP a lot back then, but we mainly use it for sinus augmentation and bone regeneration more than any possible peri-regeneration. There is some data, especially from the group from Lekovic, if I remember correctly, from Belgrade, and did study a lot platelet concentrate. Biologically, it is sound. I don't know whether, I don't think you need to buy a machine, however, and to take such a blood removal for maybe a defect of 2 millimeters. That's what I'm saying, is that maybe it's a bit too much. I would just rely on something simple and well documented.
Another question about your perio endo case apically. That is an amazing picture. So there's a student from here in Mexico. I don't know if you know it, but here in Mexico we have the specialty of endoperio, the postgrad in endoperio. So it's very special. This kind of yeah. Got invited. So
I didn't know.
Well, it's a special program, and they asked for us that, what is your opinion about the retreatment of this lesion? If you did this retreatment of apicectomy, what is your advice for us about apicectomy or not apicectomy or only curettage?
Well, as you could see, 2 of those perioendo lesions were not apically 360 degree involved. In those cases, I didn't endo, and most of the times I'm very conservative. I'm trying to do endo if the tooth is vital, and of course, unless I see that during the surgery I move around the apex. But you need to make sure that you can maintain and especially see the patient regularly, because I had one case that lost tooth vitality 3 years after the surgery. So I had regenerated all the bone. Years afterward, a granuloma appeared. So we also had to do endo treatment. So it's important that if you're not going for endo, you keep following. If you've done endo, I always do a very fine apicectomy. So what I'm really doing is, actually I can, let me see, because I should have a video. Yeah, I have a video. Do you want me to share the screen?
Yeah.
Because I have a video exactly on the procedures. Let me just see if I can download it, because that wasn't something I didn't expect it to happen. But basically what I'm doing is I'm doing a very fine apicectomy, maybe just 10 degrees. So I'm just grinding off to the point that you start to see in transparency the root canal filling. But I'm not really doing a classical apicectomy. Really, the concept is to try to remove the less tooth structure ever. Because the problem there is not the endo, most probably. The problem is the perio that involved everything. So as soon as I just grind this off, I'm happy with that. sorry, I'm trying to see if I managed to open this. Yeah, I need to download it, and it might take a little while because it's a video. We'll see if I manage. I mean,
it's like a root polishing, no? It's like a root polishing with
exactly.
Yeah.
Exactly. The only difference, Carlos, is that you do remove root substance, okay, till the point that you can see in transparency a little bit of your apically endo-treated area. Okay, so some removal is not just that you do polishing. You literally remove things. Let me also. I'm sorry. I'm trying to see if I manage to show you the case, because it's nice because you can really see the amount of action that I'm doing. But if you want, I can put back the picture. Let me put back the picture that we saw before. So maybe we can just highlight it on the picture. I'm gonna also show you some flapless application of regenerative material, which is that is really minimally with the videos. And
aim to gain flapless.
Yeah.
Is the future or is the present?
It's the present for me. I believe it's the present. No
for
discussion.
Me too.
I mean, we've highlighted in the paper that we published now nearly 1 year ago that you have a reduction of surgical need of the 30%. So the only difficulty is the technique. I'm gonna show you the technique properly because the technique is really operator sensitive. Now let me share my screen with you 1 second.
Okay. Bueno, les mandamos un saludo a todos los alumnos de la Facultad de Odontología de la UNAM y de todos los posgrados que están conectados de América Latina. Ready.
So you see, if you can actually see properly, let me see where's the arrow here. I've lost my arrow, but there is a little apicectomy here. And in this area, there is a change that was done with her, but very minor. It's just a minor grinding to the point that you see, I start to see the transparency of the root canal filling, and that's it. So I just readjust a little bit the apex, but I don't do a proper apicectomy. So this is the technique that I'm using nowadays the most. As per the flapless usage of regenerative material, okay. I'm sorry, I've opened, I don't know how many files, so always a while.
Don't worry.
Let me go back here. Okay, share screen. Okay. Can you see the slide?
Yep.
You see, we have this defect on a 3.5 bilateral. You see here we have 7 millimeter pocketing distal. Therefore, what we do is to start our instrumentation. You see there is some pus discharging as well, some exudate. And the first thing that we do is to do some ultrasonic treatment. I think the video simply is a very big one, so it takes a while. But here you see, yeah. So we start with ultrasonic treatment. That of course nowadays I'm using really very limited extent, and I'm mainly working manual. Then you see we finalizing the root instrumentation with manual instrumentation. Then we apply some Prof gel. I'm sorry, here we are doing too many things, too many videos in this presentation. So we have applied some Prof gel, we take it out, and we see just by doing a very quick ultrasonic passage on the wound. And now the most important aspect is that we apply some superfloss in the wound. I mean, I wish I could show you, but it simply got stopped. I don't know why, but okay. So you see, we are applying some superfloss, and this is crucial because by applying superfloss, we are trying to control the bleeding in the pocket. That's why we do these procedures only in very deep pockets, because such as at least 6 millimeters, because it takes time. Every pocket takes time. You have to think that each pocket becomes a sort of a surgical area per se. So it is really something that takes time. And then we apply, we leave this one for 1 minute, and then we apply our Emdogain. Now, let me see if this presentation would eventually manage to keep going or not. What we've achieved is pocket closure, and we went from 6 millimeters to 3 millimeters in that area. And you have to bear in mind that the flappers that we propose and we publish is to work under magnification, then we rinse and we leave the Prof gel for 2 minutes, then we rinse copiously with ultrasonic in the crevice, then we leave the superfloss 1 minute until we control the bleeding, and then we apply Emdogain. These allow us, for example, in defect like this one, to, you see, we have instrumentation, Prof gel, then we rinse everything with the ultrasonic, then we apply the superfloss, we take it out 1 minute afterwards, and then we apply the MD. And this is before and after, this is before and after with the pockets closed. You see, this is really the technique that I'm using the majority of the time, and this is the healing of the area that we've just seen. The application of Emdogain, not surgical for me, it's a kind of a baseline point. So when thing goes wrong, then I might consider surgery, but I'm trying to reduce the need of surgery by applying the highest minimal invasive technique. So if you want to see the concept of hopeless, I'm inviting you to check the Periocampus Herald, which is our journal that we founded to give voice to the periodontist, and hopefully shortly we'll have a column also held by our friend Carlos to talk about periodontology in Latin America, and I would love to have a consistent and frequent column on the world of Latin America, to which my heart is really close, really bound to la cultura de Sudamérica. And once again, if you need me, you can drop me a line on Instagram, and I'll try to get back to you. But check the Periocampus Herald and let me know. Thank you.
Thank you so much, Filippo. Thank you for all your kindness or all your knowledge. Gracias a todos por estar aquí en PerioMX Academy, y felicidades a las madres de Bolivia. Say hello to Mother's Day in Bolivia. So, gracias, Filippo. We're in touch, and say hello to Pisa.
Gracias a todos. Cuidado.
Cuídense mucho. Muchísimas gracias a todos aquí en PerioMX Academy. Y bueno, nos vemos el día de mañana con una presentación desde Suiza con Susi Linder. Gracias a todos. Gracias por creer. Quédese en casa. Hasta la próxima. Bye.